So we're talking about status migrainosis, and that's a really fancy name. You could actually say status migraine. So just so I won't get tripped up, I'll say status migraine for now. But it can also be called refractory migraine or prolonged migraine or intractable migraine. There's lots of slang terms for migraine things, but basically it's a migraine. The patient already has a diagnosis of migraine, whether it's episodic or chronic, and they're using their usual attack plan for that migraine, yet it won't break. So the pain, so migraine is supposed to be a headache that is recurrent and episodic, meaning you have a headache that lasts anywhere from 4 hours to 72 hours, but then it goes away after 72 hours, or it should, and then you have periods of no pain and no symptoms, or less symptoms, where there is the interictal period that we could talk about. But you should have no, your pain should be zero, and you should be able to function. Now, that in episodic migraine is people or patients that have less than 15 headache days per month, and then chronic migraine is for patients who have more than 15 headache days per month, and many of them have headache 30 days out of the month. So the patient already has migraine, and they may have never gotten the diagnosis. 50% of people who have migraine are misdiagnosed with sinus headache, tension type headache, cervicogenic headache, or they just never went and got a diagnosis, or they were misdiagnosed. So patients that present with their usual headache type, but it's not responding to any of their medications, it's not breaking, it's prolonged further than the 72 hours or their normal time for their headache disorder, and it's disabling. So two things: it has to be longer than your usual migraine. So if you have migraine, this is longer than your usual typical migraine for you, and it's not responsive, and it's disabling. You can't function through it. So now I'm also going to talk about medication overuse headache, because there's going to be a lot of overlap. And medication overuse headache is a term we use for sometimes when patients have not been offered really good prevention strategies or prevention treatment, or never gotten the diagnosis. They're just taking a lot of over-the-counter medicines or something in their cabinet that they got for pain once, and they're using it once or twice a month, and then their headache frequency increases, and then they might start using it twice a week, and then they're trying to function at their job, and then they're using it 3 and 4 days a week or 5 days a week, and they can't predict when that migraine is going to happen. So they want to function and bring home food for the family and money for the family, so they go ahead and just wake up and take an Excedrin and go to work. So patients who are taking medications for the acute phase of migraine to attack their headache to make it go away more than 2 days a week are at high risk of being medication overuse headache. So a lot of times when somebody presents with an intractable headache in the ER or the urgent care, that could be part of their medication overuse headache. So basically they went from having episodic headaches and it transformed into chronic migraine through the complication of medication overuse headache. So we try to tell our patients, caution, if you're using having to treat a headache more than twice a week, you could be getting near the threshold of medication overuse headache, and that puts you in a high risk of getting into intractable migraine or status migrainosis. So what are some of the risk factors? Okay, so the number one risk factor for status migraine could be stress, okay? Some patients have more of a risk, and I'll go through those, but patients can get into status migraine easier if they already have chronic migraine. So if they have high frequency headaches, they've already got 15, 16, 17 headache days every single month, with 8 of them needing treatment, migraine treatment, then they're going to be at higher risk for having status migrainosis. But there are some people who have infrequent headaches, like somebody who can have headaches maybe only 3 times a year. They have their migraine, they get their aura, they vomit, they have to go to bed 3 times a year. But if there's a stressful event, like maybe a wedding or something, or a divorce or something, that stressful event, or even sometimes an illness, can cause them to go into status migrainosis as well. So people who have episodic migraine are not migraine. So we'll discuss that. And then some of the risk factors are going to be, like I said, high frequency attacks, older age, stressful life events, mood disorders, and the use of either opioids, narcotics, or barbiturates. And so my caution to anybody listening today is don't ever use any controlled substances to attack your headaches, because we have evidence and data that shows that's going to increase your risk of transforming from episodic migraine to chronic migraine, and it actually is a really high risk factor for medication overuse headache. And it's not known, we have evidence that it's not the best treatment for migraine attacks. So it should never be used for prevention or for attack in headache medicine. So always tell your provider you don't want any opioids, you don't want any barbiturates. And what do I mean by barbiturates? Well, opioids are Loratab, Percocet, all that stuff you can see on the news, the stuff you got when you had surgery for your foot or you had a C-section. And then barbiturates were first developed for like tension type headache. They actually have no FDA indication for migraine, but they're used quite frequently, unfortunately. But they've been banned in all the other countries except for here. So I'm talking about drugs called Fioricet or Fiorinol or Esgic, Frenulin. There's a lot of other names, but if it has any barbiturate in it, then you really want to stay away from that, because that's going to really increase your risk. So let's talk about prevalence. Well, there's been no data to study what is the prevalence of status migraine, or how many people get into status migraine. But like I said, people who have chronic migraine are going to be at more risk. And out of the population, about 12 to 18% of the US population has migraine if they're women. And then out of the men in the US, about 6% have migraine. And then unfortunately, about 2% of the population, the US population, 2% of the general population has chronic migraine. And so those people are going to be at the higher risk for having a non-responsive headache and being in medication overuse headache as well. So it's a very rare condition. Status migraine is very rare. But in headache centers, like my headache center and all my colleagues that you've seen on this amazing channel, most of us all have to deal with our patients calling us saying, my headache medicine's not working, my plan's not working, what do I do? So in most of our centers, headache only centers, or a division of their practice that is for headache only, we have an urgent care kind of treatment center that's like an IV infusion room, or we also do nerve blocks and other things like that. We'll get into that later on. So one of the keys that's really important about establishing the diagnosis of status migraine is the history, okay? The history is really important. And you want to see if they have a history of migraine, whether it was episodic or chronic. If you want to know how frequent their headaches have been before now, did they have chronic migraine? Do they have medication overuse headache? And what is their education level about their diagnosis and their treatment plan? And so now I'm going to talk to you about, are there any non-medical treatments for status migraine? And basically, there's been no study on non-pharmacologic interventions for status migraine. But things we do know that work for migraine in general are psychological counseling, biobehavioral counseling, what we also call cognitive behavioral therapy, yoga, mindful therapy, neuromodulation devices, education, support groups, essential oils, certain kinds of elimination diets. All of these can benefit migraine as a whole. So if you incorporate that into your lifestyle, you're probably going to decrease your risk of having frequent headaches and decrease your risk of getting into status. All right, and let's see what's next. Very important is what should you have to arm yourself against status migraine if you're at high risk? So if you know, and some of the people who are at high risk, lower socioeconomic status, lower support system, if they have psychological comorbidities like anxiety and depression, those can increase your risk. So if you know you're at higher risk, or you've been in status before and you want to prevent that, what should you do? Well, you should have what we call the toolbox or the kit. And I tell all my patients, male, female, that you should always have your attack plan, your drugs, in your car, your purse, and at the office. Because a lot of patients say, well, the reason I got into this mess was because I didn't have my medication with me. And another thing you want to prepare yourself with is you got to have a headache diary. So if you're not keeping track of how many days you have a headache and how many days you have a bad headache and how many days you had to treat a headache, then you need to do better. And there's actually on our website, which is MississippiMigraineCenter.com, I think there is a headache diary you can find. There's a million on the internet, and they're all free. I just like this one where you can see 6 months at a time, so you can see how your trend is doing over 6 months. And then, so what is an attack plan? What do you take for your migraine? So an attack plan, it varies based on what your comorbidities are. But like in a typical, I'm gonna have to get some water. A typical attack plan is the goal of it is that it rapidly eliminates your pain, rapidly, not like over 8 hours, but rapidly eliminates your pain, and it restores you to normal functioning so that presenteeism is when you stay at work, because you know if you leave again, your boss might fire you. But presenteeism is when you're kind of only functioning at about 50 to 75%. You're doing this, you know, at work, and you're acting like you're doing work, or you might be even seeing a patient or you know, in a courtroom doing your job, but you're just not functioning at your best, and it's really hard to work and with all the, because migraine's not just headache, it comes with all these associated features like sick to your stomach or nauseated or sensitive to light and noise, and usually at work we can't escape those. So we want you to have this plan, so it should be with you at work or wherever you might be. Everybody says, oh, I was at the mall and didn't have my meds. I'm like, every woman I know that comes into the headache center here has a massive purse. I'm like, you should have your meds with you or in your car. So we want them to get rid of the pain quickly. We want their to restore their normal function. We also want to make sure that headache doesn't rebound the next day or even recur the same night. So the key is to be completely free of pain for 72 hours, meaning you really broke that headache, okay? So how do we do that? In our clinic and several of my colleagues, we use the Toolbox approach, which is a combination therapy where you combine a triptan or an ergotamine, or we're gonna have new meds coming out that are other what we call migraine-specific medications. So migraine-specific attack medicine, we also call them attack, acute, abortive, because we're trying to abort that headache attack. So we want a triptan, an ergot like DHE, and then we're going to have some ditans are coming out and G-pants are coming out in the future, which will be migraine specific. And then we want to combine that typically with a non-steroidal anti-inflammatory that has evidence in migraine. And the one we use the most is diclofenac, because we can get it in really fast if we have the right preparation. And that's a prescription only. Other medications that have efficacy do include like aspirin and Tylenol and Aleve and ibuprofen. But the problem is, if those were working, you probably don't end up in status migraine. So, and also we try to take you off of those, because things like naproxen, which is Aleve, it has a very slow onset of action. So it can prevent rebound, but it's not going to get in fast to do the job. So a lot of times we can combine our triptans with naproxen, but a lot of times we use diclofenac. Those have a lot of evidence in headache medicine. And then I do the 3-drug combination of adding what we call a neuroleptic or an antiemetic. And the two that have the most evidence are going to be, and also they don't cause sedation as much as, say, Phenergan does, prochlorperazine, which is compazine, and that's easier to say and spell, or Reglan. And I'm going to show you the data on that. That's very exciting. So some people say they're not even nauseated at that time, but even if they know they have any risk of getting into status migraine or risk of having to take 2 of their attack meds or risk of it recurring a rebound, I tell them to go ahead and take all 3, because we know the GI system is not really working well in migraine. When you have a migraine, we have evidence from Dr. Sheena Arora that the gut shuts down. So getting something in that's going to increase your gut motility is really going to help those other as well. And then patients say, well, what do I do if that fails? What if I took my triptan and my NSAID and my compazine, and 2 hours later I'm still having a headache? Well, the goal is hopefully you had enough education from your headache specialist to know that you can repeat that triptan, usually 2 hours later. If it's an injectable, you can actually repeat it an hour later. And then we have nasal sprays, and we're going to have patches and all sorts of non-oral options. And we really harp on the non-oral options because if the gut's not working, why are we putting pills in it? So we give all of our patients that come to see us a non-oral treatment option. So they have either a nasal spray or an injection that they can use at home, or a patch, or any delivery system. If they would take a rectal suppository, we would take anything to get their medication into their bloodstream, bypassing the gut, because it just is not highly functioning. It's not the best way to get medication in and bioavailable. So, so you want to have those medications. If you've taken your triptan twice and maybe your NSAID twice, and it's going on prolonged 12 hours, you're not getting any relief. Hopefully, if you're with a headache specialist, with us, you can call and get in the same day or the next day for IV infusions or nerve blocks, and we'll go into those in a little bit. Worst case scenario, you don't live anywhere near a headache center or a headache specialist, or your neurologist can't see you for 3 months, and they don't see you when you're needing urgent care for your headache that won't go away, and you're trying to get to work tomorrow or get to your daughter's wedding tomorrow, and you need to get that taken care of now. If you don't, you might have an urgent care center, which you can go to your urgent care center and ask for certain shots or IV infusions that we're going to show you about. Or you can go to your emergency department, which is the last place you should end up with a headache. And also that not if you have an unknown type of headache, but if you have migraine, that's the worst place to end up. And then they also run a lot of tests that are unnecessary, increase the healthcare cost. And then a lot of times they'll give you Demerol or Dilaudid or some sort of narcotic that's not good for headache, causes rebound, and then they'll give you no treatment plan when you leave, so you're just in the same boat from where you started. So it'd be a great idea if we could keep more patients out of the emergency department. All right. And so what is prevention? Prevention is a medication. It used to be a medication that you would take orally every day, but now we have injectable medications as well that you can take either monthly or quarterly, and you take them monthly or quarterly, and they prevent your headaches. Now, we haven't got a magic wand that fixes everybody yet, and we don't have a prevention that as soon as you start it from day one, you're going to have no headaches. Unfortunately, we're working on that, studying all the biology of migraine, which is fascinating. But what we do have is a goal. Our initial treatment goal when we start you on a preventive medication is to cut down whatever your typical last 3 months frequency is. Say your last 3 months you had 18 headache days per month on average. We want to cut that down to 9, but that's still not good, especially if you have any days of disability. Our goal is to cut that down even further, because with good prevention, you have minimal side effects. You have maximum efficacy, like meaning you can get up to a certain dose that's really decreasing those headaches, that your attack medicines work every single time you take them, that you don't have to take multiple doses of your attack medicines, and that you never, ever, ever have to call in sick at work or at school each month. Okay, so that's the main goal of prevention. So if you are going to the emergency department and you do not have a headache specialist with a good prevention plan and a good toolbox and a good rescue plan, then go to another headache specialist. So ask your headache specialist. Not all general neurologists are headache specialists, and ask them if they have an infusion center for refractory migraine. Ask them if they do nerve blocks for patients who have intractable migraine or status migraine. So those are really good questions to ask. But prevention is paramount. You need psychiatric referrals, because dealing with migraine is stressful, even in between attacks, because the attacks are kind of like running from a stalker. You never know when he's going to be there again. So it causes a lot of anxiety. And other comorbidities should be addressed, education. And then you want close and consistent follow-up. You don't want somebody giving you a drug for migraine and saying, good luck with that, call me if things don't work out. So you want to be seen by your specialist at a minimum every 3 months. In our clinic, we have the luxury of seeing our patients okay? So I've talked about prevention and the diary and the toolkit. And I'm going to show you a little bit about our treatment algorithm. And like I told you, there are two different options for what do I do when I have a bad headache. Like if you have the option and the luxury of having a headache specialist, and you can look them up if somebody's certified in headache medicine, either through the National Headache Foundation or through the United Council of Neurologic Subspecialties. So there are about 800 trained headache specialists that all they do and all they focus on is headache. And we're trying to train more providers who want to get interested in headache disorders, because it's very much a passion for those of us who treat headache disorders. And so I'm gonna look at my time. Okay, I need to wrap it up. So I'm gonna go a little bit into the treatment plan. If you've taken your oral meds, if you've taken a non-oral medication at home, if you've done everything you could at home to avoid that headache from festering and lingering, then you should get into your either headache center, that would be the priority, or urgent care center. And then last resort, you'd have to go to an emergency department. Now at a headache center, I'm just gonna hand up two handouts. So a lot of times we'll do these occipital nerve blocks. This is from the American Headache Society Toolbox. And you can find that all over the American Migraine Foundation website. And then this website's not available anymore, but we do more than just occipital nerve blocks. We do nerve blocks for headaches. So we do, I call it the total head. We do peripheral nerve blocks where we do the greater and lesser occipital nerves in the back of the head, because the C2 nerve root is involved at the brainstem. And then we do trigger point injections on the head and neck, because most of our patients, 70% will say that the headache started in their neck and then moved forward or stays back there. And then we also, the trigeminal nerve is very much involved in the transmission of these pain signals. So we're trying to do anesthesia on those areas. So, and the trigeminal nerve is still part of your peripheral nervous system. So we do auriculotemporal nerve blocks bilaterally, and then we do supratrochlear. There's a little notch there. You can feel it right there where your eyebrow is, and then supraorbital. And then I do a few extra in the temple, just little trigger points. But if you can get, I've had so many people who come into us daily that, you know, we ask them what their pain is when they come in, because they came in with an urgent headache, and it's supposed to be 0 to 10, and they'll tell us that it's 12. And I'm about to get to the questions, but I'm going to get onto this treatment algorithm on our website, which is MississippiMigraineCenter.com. And you can find these for free online too. The Cleveland Clinic has a good one, but this is what we would love patients to take with them, because not every patient can be treated the same, because they might have a contraindication. So this is how to triage basically headache in the emergency room. But the cool thing about this is if you bring something like this, it says don't use narcotics, do not use narcotics, and look them up in the PMP. So basically, if you come in with something that says, I have migraine, this does not treat cluster headache, by the way, I have migraine and I want these drugs, I do not want narcotics, it's danger, do not give narcotics. And they read this, they're more likely to treat you with compassion, because they realize that you're not there for Lorcet or Percocet, which unfortunately headache patients don't do as much as drug seekers who really don't even have migraine. They're just using that as an excuse to get drugs. So they've kind of made it difficult for people. So you can find this on our website. And basically, if they bring it into their provider, their urgent care provider, it has a little website up here that shows them all the references to Silverstein and Mia Menon and Todd Rosen. And so they will know that everything is data-based. And by the way, the most important study they did was they did a drug comparison study on treatment in the emergency room, urgent care treatment in the emergency room. And it was prochlorperazine, which is compazine, which is just an anti-nausea medicine. Compazine versus Dilaudid or hydromorphone. And compazine won so well and so quickly, they actually shut the study down early, because the people on the Dilaudid and Demerol were not getting better. They were not getting relief of their headache. So what I would prescribe is either compazine or Reglan. And then I would add a sumatriptan injection if they haven't already had 2 sumatriptans. The injectable works better, and a lot of times they have that in the emergency department. And I would always add Couture migraine works really good. And Ramey Burstein has a lot of work about, for refractory migraine, adding this IV Toradol or IM Toradol to a headache that's been there for a very long time helps shut off that central sensitization and helps get you out of status migraine. Then reevaluate. You want to get an IV established. IV is much better than IM if you can get it, because the key to treating migraine in the ER is a combination of drugs. So if you have IV access, you can use the combinations, okay? So that's my first combination. This is first line based on data. And then my second line is sodium valproate or Depakote in an IV. And then you can also repeat your sumatriptan and either your prochlorperazine or your Reglan, which is metoclopramide. And there's all sorts of contraindications for different people. That's why you should bring this to a trained provider, and they can also look up the contraindications. And then the last is magnesium sulfate. Now, magnesium does not have a ton of evidence that it works in status migraine, but there is some evidence for migraine with aura, and I know a lot of my colleagues use it. It also can help bring down the blood pressure, so it can be a win-win if your blood pressure is elevated as well. And then you can also do an extra dose. But anyway, all the information's here. It's on our website. You can get that. You can download the Cleveland Clinics for free.